Welcome to INOvators, a series where we sit down with thought leaders in the healthcare technology space to talk about news and trends impacting the industry today. My name is Justine Giancola. I'm on the corporate communications team at Inovalon, and joining me today is Karen Knight with Face Rock Enterprises. And for those of you following our INOvators podcast, you may remember we actually sat down with Karen about a year ago to talk about revenue cycle management for tribal health organizations. So Karen, thank you so much for being here again today.
Glad to be here. Quite an honor.
So before we get started, I first have to congratulate you on earning Innovator of the Year as part of the inaugural Inovalon Impact Awards. The work that you have done to support tribal health organizations is exceptional and certainly deserving of this award. So congratulations.
Thank you. It was, I was quite it really was a humble thing. I wasn't expecting, I just was honored that I was nominated. And the fact that it was awarded to me is really a wonderful, just a very much a blessing to me. Thank you.
Of course. Well, like I said, very, very well deserving. But today, let's talk a little more about tribal health organizations. So for starters, tell us about the work that tribal health organizations do and what are some of the unique challenges that they face?
Well, as we know, after the pandemic or during the pandemic, additional funding came to tribal health. And so they're all starting to want to open up their own health system. So they've gone from, they were using Indian Health Services, and now we're seeing many, many tribes all over the country say, you know what, Indian Health Services, we don't like the way you've treated our patients. We don't like the outcomes we're getting. We think we can do a better job. We want you to pay us that money so we can take care of our own patients. So we're seeing a lot of tribes start to branch out and start their own health systems where they didn't have those before. For many of you may not know, the tribal health is funded for 40% of the cost that it is to render the care. And it's actually funded less than the prison system. So they really depend on third-party revenue because that is the bridge that fills that gap there so that they can provide that care to their patients. And they're also starting to open up to more non-native patients too, because they are getting some of the state-of-the-art equipment and they are starting to bring in some of the top specialists, top doctors in the country. So they're pulling in a lot of people who are non-native also.
Okay, so kind of taking it into the reimbursement conversation here. You know, reimbursements are critical to any healthcare organization, but tell me a little bit more about the impact that even a small reimbursement can have to a tribal health provider.
Yes, good point. There are A1C is a common test that's done, and we know in Indian healthcare there's a lot of diabetes. There's a lot of heart disease and diabetes. So even the smallest amount really matters. So an A1C test can be run, and it takes the average glucose readings that you've had for about the past 6 months and gives an average reading on there. And it's real important. That number is part of the quality initiatives, or part of the HEDIS measures that CMS has put forth that are now being required by your Medicare managed care, your Medicaid, your Medicare Advantage plans, your Medicaid managed care. And so they are looking at those measures to determine the quality of care that's being rendered. Well, A1Cs are always run in Indian healthcare, and it's a common test that's run. However, the providers don't always know what the diagnosis code should be that meets medical necessity. There are local coverage determinations and national coverage determinations. So most of your procedures are going to be paid based off the CPT or HCPCS code. But for these medical necessity codes that have the national determination or the local determination, you've got to have a corresponding diagnosis code that matches. Or if you don't, the claim is denied and it does not for not meeting medical necessity. Now, the providers, when they go to school, they're not taught this is what medical necessity is. So they don't always know. So we have to educate providers on that. And when they run this test usually only pays $5 to $10, so it's not much. So when you're getting denials on that, you're thinking, oh, well, I don't have time to do an appeal on a $5 to $10 claim. I've got hundreds of these because a provider may not be collecting that correct information. But because CMS has come through, they've decided that we need to improve the quality of care in this country, and that they've come post-pandemic, they begin to ask questions like, why does it cost more money in America to have health care? And why are we seeing less health outcomes for the amount of money that we're spending? So they wanted to really focus on the quality initiatives. So part of those are the HEDIS measures, which do the preventive codes that are out there. So A1C is on that list, and it's a big one. And it's a very frequent one in Indian country because they're always monitoring that. And they do a very, very good job of it. They have some special diabetes programs, but they're not getting credit for it. Because if you don't pick that certain diagnosis from that list that matches for that test, it's not going to be covered, and then it gets denied. And what happens are, you've heard of star ratings that are out there. There are star ratings for managed care organizations, and then there are star ratings for providers. I had one medical director come to me and he goes, I've always been a 5-star provider. And all of a sudden, I'm a 2-star. What happened? What happened? Why am I a 2-star provider? I've checked. I don't have bad ratings. Patients aren't rating me bad. I render quality care, blah, blah, blah. So he was real upset. When we dove into it, we found out that it was just those star ratings were based on him not getting his A1Cs with the correct diagnosis. So it brought him up from a 5-star to a 2-star provider, which was very offensive to him, to say the least. But it also, then when patients looked at him to see, are you a good provider, they would get a 2-star thinking he was a 2-star provider. And it had nothing to do with the quality of care. It's just when that claim got denied and didn't go through, that's how they're measuring it. So that's how they're capturing that measure, is it goes through and it gets billed. And when it gets billed, that's when they find if they've got the correct diagnosis. But the claims were stopping and not actually going through, so that really affected them. Now, the amount of money involved in this, because you're thinking, oh, $5, $10, what's the big deal? Well, they were losing about $100,000 every quarter. And then on an annual basis, because there are value measures that are out there and we're changing, remember, all our contracts, everything is starting to change to match the quality of care that's rendered. So they were seeing that the HEDIS measures that are in there were not being met, and therefore they weren't eligible for that value-based payment. It was $1 million for the year. So over these silly, tiny $5 payments, it cost them approximately $1.4 million for the year, which was awful to lose that kind of revenue. So it happens not only in Indian healthcare, but across the board for all types of services that are rendered by providers.
Yeah, absolutely. And clearly, even those little reimbursements, they clearly do add up.
They definitely do, yes.
Kind of on that same reimbursement vein, can you talk a little bit about the relationship between a non-tribal health provider who might get a referral from a tribal health organization, and are there reimbursement challenges there?
There are some reimbursement challenges. FaceRock has worked to help educate providers that are outside of Indian healthcare, because there's a system in place. I had one person ask me, they go, is this mystical in some way? I said, there's no mystic to it. You just don't know the rules. So basically, they have to issue a referral that goes outside. So there'll be a authorization number that will allow that. But you've got to follow the rules. You need to get in contact with your tribal provider and ask them what they need from you. And then you submit it back. And as long as you submit the information back, there's no reason why you shouldn't be paid.
Okay. So I think, off the reimbursement topic and something that's kind of off topic from our whole conversation, but Karen, it's always fun to sit down and talk to you. I would love to know, can you give me a lesson learned since the last time that we talked a year ago?
Oh, yeah. I've got several, but there's one that has really stuck with me. So I play this game with my granddaughters. They're 7-year-old twins, and I bring something from my house, they bring something from their bedroom, and we switch. It's called switcheroo. So they brought in these hair barrettes, and the hair barrettes they said, I don't think we can trade those. I don't think your mom's going to like that. She probably uses these. She goes, oh, no. She said these are not good ones, and they're too tight. And I thought, how can that hair barrette be that tight? I mean, it either clips down or it doesn't. And so I thought, these little girls don't understand what they're saying. I mean, there's nothing wrong with these. They either clip or they don't. Maybe they put too much hair in there. Anyway, so much from there. I went home. I had all the barrettes in my hair, and they fixed my hair. And for whatever reason, I did not take them out that night. We were tired when we got home, and I just fell asleep. Well, I woke up, and I looked on my pillow, and there was all this hair on my pillow. And it's various lengths of hair. And I look at my husband, I said, did I lose all my hair? And he said, I think you need to look in the mirror. When I looked in the mirror, I realized that those barrettes were sharp. That was the term that should have been used. And I apparently moved my head at night when I sleep, and it had sawed off the hair. So basically, I learned a big lesson with that. Had those little girls were trying to tell me something, while they didn't say the barrettes are sharp, they said they were too tight. They were trying to tell me there was something wrong with the barrettes. But I thought I was a good listener, but apparently I'm not. And I really learned I need to listen more. So we need to listen to our employees, listen to our patients. They may not use the right term, so they may say something, but they're trying to tell you something in there. Those little girls were trying to tell me it wasn't too tight. It's just that those barrettes were bad and sharp. So had I listened, I would not have bangs in the back of my head right now from where the clips have been. So basically, my lesson learned is listen to your patients, listen to your employees, spend the time to dive in a little bit more. Had I even asked another question, I probably wouldn't have bangs in the back of my head, and neither will you.
I think it's a funny story, Karen, and but on a serious note, that's advice that we can take in our personal lives, professionally, across all industries. So I think certainly a very important lesson. And Karen, it is always great to sit down and talk with you. Thank you again so much for joining us again today. And of course, to our audience, thank you for tuning in, and be sure to join us again next time.